Hi, how are you today? It is Tuesday, May 12th, and I'm going to continue with my discussion of Black Man in a White Coat, written by Dr. Damon Tweedy. Changing up positions because something wasn't working on the computer, so I switched over to my cell phone. Hope everybody's doing well today and staying safe. So we're still working with this book, Black Man in a White Coat, written by Dr. Damon Tweedy. And continuing to talk about health disparities. So last Thursday I read a little bit and then had a little conversation, and so that's what I'm going to do again today. And hello, Miss Yetanel. Okay, so let's start here. I'm on page 188 for those of you who have the book, and for those of you who might be purchasing it and want to know where we're talking from. I soon discovered that there too, race was often a factor in the hospital and clinic, and he's talking about his psychiatric training. Psychiatry, like other areas of medicine, operates on a two-tiered system of public versus private care. In many ways, however, the distinctions are more blatant. Those with private health insurance or who have the ability to pay out of pocket have access to private facilities and providers, whereas those who don't or can't are relegated to a public system that has come under ever-deepening budget cuts. As a resident, I worked in both settings and saw the disparities play out on a daily basis. A typical case might involve a young woman who'd come to the emergency room following an overdose on prescription pills. After doing the initial medical and psychiatric evaluation, the next and most important detail was to determine her insurance status. This single factor would determine whether she went to our inpatient unit or one of several private hospitals in the area where there would be other depressed and anxious patients like her, and she could get individualized treatment, or whether she was shipped to a state hospital where she would be surrounded by aggressively psychotic, manic, and antisocial personality disorder patients. Invariably, it seemed, the private patient would be white, the public one black. The contrast was most overt with substance abuse treatment. Much of our inpatient psychiatry work during the first 2 years of residency training involved people with alcohol and drug problems. In Durham and its surrounding areas, cocaine and its cheaper derivative, crack, remained the street drug of choice well into the 2000s. In local public settings, the usual protocol was to admit a patient for 4 to 7 days for alcohol detox and 2 to 3 days for cocaine withdrawal if accompanied by suicidal thoughts. The patient would then be discharged to outpatient treatment. Occasionally, a person might be accepted to an off-site residential program, 14 to 28 days, but that typically required them to have established outpatient care first and to have remained alcohol and drug-free before they could be enrolled. Without health insurance, I've skipped a few sentences. Without health insurance to cover the cost of private office care and a 3-month wait to be seen at a county clinic, a young man that he was working with came directly to the hospital. Because the alcohol and drug detox unit was full, he was sent to the general admissions wing where he was surrounded by patients who had personality issues, who had severe mental problems. The young man's name is Steve. He had arrived at the hospital on a Friday evening after work. Unbeknownst to him, that was the worst possible time. All hospitals operate with skeleton crews on weekends, but this tradition was more pronounced at the state psychiatric facility. There, one on-call weekend doctor at any given time covered the entire hospital of several hundred patients. Out of necessity, this psychiatrist saw only the patients who were having crises. After meeting one of my harried colleagues for a brief assessment when he first arrived, Steve didn't see a physician or a social worker again until Monday. He said to him, this gentleman, Dr. Tweedy, when he came in on Monday, he said, "I came here for help. This is the first time I've seen a doctor or therapist since I've been up on this floor." At the point they came in on Monday, they were planning to discharge him because um, he had started to come down. He had, started to detox over the weekend without any assistance. So they were planning to discharge him. So he said his boss had given him a month to get treatment, and this gentleman had become addicted to medication after his daughter and wife were killed in a car accident. So they prescribed grief therapy for him. Said, like many other people with substance abuse problems, he'd come to the hospital seeking a jump start toward a clean life. Spending 3 days around psychotic patients hadn't been much help. Compared to many of the drug-abusing patients who came to the state and VA hospitals, Steve had several factors in his favor: a stable job, no criminal record, no history of failed treatments or misuse of the medical system that made him a good candidate to succeed in a counseling-based inpatient program. But the next available opening was more than 3 months away. So he was scheduled for discharge, and the social worker told him that they were able to get an appointment for him for the next Friday, and that was the earliest they could get him in. He said he wasn't. They had done the best they could. It just wasn't what he expected. So private rehab facilities have different processes. So their programming generally consists of several daily group therapy meetings along with individual sessions at least twice a week. Family involvement is a crucial component of the treatment, and the patients had a variety of constructive ways to spend their downtime. While it's true that in the public system succeeded in staying off drugs and some in private programs fail, it is hard to imagine that this more comprehensive treatment did not give patients a better chance at success. The private facility claimed that the majority of their clients remain clean after 3 years, and in contrast, the public facilities, most of the people who have drug problems don't make it a year without relapsing. So he says that during his time working at a private facility, over 100 patients passed through, but just one was black. In contrast, blacks routinely made up more than 50% of the people seeking drug treatment at the public facilities where he worked. There was no reason to think that overt racism was behind these numbers. Instead, as is often the case in medicine, the disparities were more socio-economic than racial, but the economic disparity largely plays out among racial lines. And just as an aside, I want to tell you, hey Emily, hi Nina. I want to tell you that at one point we had to take my mother to UNC Chapel Hill because she was over medicated and she wasn't doing well, and so that's what the doctor suggested that we do. It was a Friday. It was not a good day. On the drive over to the hospital, my brother called from California to say that his partner had passed, and it was just a hard day. So when we got there, it was a Friday. She waited. I think we were in the ER probably 13 hours before anybody came to see her, and I was pretty nasty by then because I didn't realize that this was the case when you are trying to get someone in a psych unit. So the people I knew got in quicker, even though they came in after her. There was a young man who came in, and even as they were bringing him in, he was talking about flying. He was trying to stand up on the gurney, and they had to physically restrain him. She wasn't, that wasn't an issue for her. She was just over medicated. And so she was finally admitted, but it took 13 hours for us to see a physician other than the people who admitted us, and for them to find out, to make a determination that it was time, that something else needed to be done. So, okay, back to book discussion. Um, okay, so we're going to talk now about what he calls the evolving rationale for affirmative action in medicine. So, 40 years earlier, and of course, this book was written in 2016. With images of Jim Crow still fresh in America's consciousness, affirmative action programs were started in the notion of redressing historical inequalities in access to education and job opportunities. In medicine, the effect was quickly felt. By the mid 1970s, the proportion of black medical students had nearly tripled. Mind you, let's remember that there were only 2 black medical schools from 17 to the 70s. The first main challenge came to this new order was the 1978 U.S. Supreme Court Bakke case, where an applicant brought suit against the California Medical School, asserting that his rejection stemmed from the school's policy of setting aside slots for minority applicants. The Supreme Court agreed that the quotas were unconstitutional. Hey, Annette. Hey, Lana. But allowed schools to consider race toward the end of creating and maintaining a diverse student. Guided the affirmative action landscape until the mid-1990s, when a second wave of legal protest emerged, buoyed by a University of California regent's ban on race-based preferences and a federal appeals court ruling that struck down race-based affirmative action programs. The diversity argument had also come under assault. Motivated by these challenges, as well as the persistent problems of health disparities among black patients, several researchers in the mid-1990s began publishing studies that looked at the role black doctors played in the care of minority patients. They found that black doctors served black patients at 6 times the rate of other physicians, that black physicians were far more likely to treat patients covered by Medicaid, and that the supply of physicians was lowest in areas with higher numbers of black and Hispanic patients. Over time, a related group of studies reported that black patients tended to have more positive interactions with black physicians. The conclusion from these articles was that increasing the diversity of the physician workforce could help reduce racial inequalities in healthcare, and that was advanced by the American College of Physicians, the Institute of Medicine, and the Association of American Medical Colleges. And so this became the lead argument for affirmative action in medicine. But this also has shown its limitations, according to Dr. Tweedy. Some of the research in this area has shown no additional benefits to black patients, while critics have argued that several influential studies were either methodologically flawed or overstated their conclusions. And so then this says that the focus on same race pairings overlooks a larger aspect of U.S. medical care. So international medical graduates constitute about 25% of American doctors. The vast majority are of Asian and Middle Eastern ethnicity. In many settings where poor patients, black and white, are treated, these graduates, much of the studies did not include that percentage of doctors. So in the 2005 essay, an Indian physician practicing in New York at the time examined those issues in his description of caring for an elderly black man with cancer. At the end, he questioned the wisdom of moving toward black doctor-patient pairings as a targeted goal, wondering whether this might close the doors to self-examination and self-improvement among physicians. Okay. So I'm going to jump over to, he has a chapter called Doing the Right Thing. And he says, the choices that we make have a profound impact on our health. So he's talking about personal choices now. Sometimes it's a single, simple decision, wearing a seatbelt or a condom at a given moment, for instance, that can have far-reaching consequences. More often, though, it's the daily decisions repeated over time that catch up with us. Smoking cigarettes, abusing alcohol or drugs, eating too much and too many bad foods, and exercising too little all can lead to an array of diseases. Of the 10 leading causes of death in America, among them heart disease, cancer, stroke, and diabetes, each is strongly influenced by our. While all of us make decisions that shape our health, the reasons we make those decisions are more complex. A large body of research has shown that the important role of culture and environment, socioeconomic status, both as we begin life and as we traverse it, is paramount. Whether measured by educational level, income, occupation, or some combination, low socioeconomic status is linked to a wide range of health problems and higher mortality rates. Low income settings adversely impact individual behaviors such as smoking, drug abuse, nutrient poor diets, sedentary lifestyles, and less likelihood of following medical treatments. These negative patterns in poor neighborhoods often become self perpetuating. Clearly, such factors have a direct effect on health disparities as black people remain in poor neighborhoods. As black people remain on average at the bottom of the socioeconomic scale. But putting all the blame on socioeconomic status and personal choice didn't feel right. Was it possible I was making excuses for inattentive medical practice? Looking back to medical school, I remember little instruction on how to address the role of lifestyle habits on our patients' health. For example, we learned how cigarettes and alcohol damage the body, but not about why people smoked and drank, or how we might intervene beyond prescribing a handful of modestly effective medicines. This biomedical focus persisted as we transitioned to the medical wards. Patients on our services were broken in some physical way, and our job was to fix them, or at least to make them temporarily better, whether through surgery or intensive medication. A high premium was placed on doing something, which meant using your hands or your knowledge of pharmaceuticals. During my general medicine rotation as a second year student, our team admitted a 60-year-old black man with chest pain. He had hypertension and high cholesterol, two risk factors for heart disease. He was also about 40 pounds overweight. He was the sort of patient we saw dozens of times throughout our training. After all of his tests came back normal, we discharged him with a prescription for aspirin, a blood pressure medication, and another pill to lower his cholesterol. This is the key. The doctors told him he should lose weight, but did not offer any guidance on how to improve his diet or integrate exercise into his life. So he's saying here that that's something that they just assume you ought to figure it out or you ought to know. And that's not always the case. And I will tell you, if you are working hard, if you are working one or two jobs a day to try to make ends meet, the last thing you think about is going and get some exercise because you're tired, or you might be in a rush. You might have to catch a bus. You might miss a dose of medication. So one of his friends says that they weren't that was for their primary care doctor. They came in through the emergency room, and they're there to deal with life and death stuff. But the doctors at the time of the conversation were sitting there eating unhealthy things themselves. Okay, so this focus on biomedical treatment over preventive care is not limited to Duke or similar schools. Indeed, outpatient primary care physicians are often no more inclined than other doctors to have this discussion, even for diseases where the interventions are vital. There are many barriers, among them money, so dietary counseling is reimbursed poorly compared to medical procedures. Time, physicians often see patients every 10 or 15 minutes, and the sense that nutrition talk is better left to dietitians, and that doctors should focus on their expertise, which is prescribing medications, interpreting tests, and performing procedures. In addition, experience has made many doctors cynical about patient behavior and the likelihood for change. So, confession here. I am diabetic. There are things that I like to eat, and during the pandemic, it's been worse for me. That's kind of been part of my stressor. So I'm taking my medication the way I should have. And I'm telling you this because I am making myself accountable now. Um, I'm I've started back on my medication. I'm trying to do better, and I'm sure my doctor's gonna kick my butt when I get there later on today. But that that's why I go. I need to be accountable. I need to be held accountable, and so but I need to be accountable to myself. And I can't blame what I do on what I don't have time to do. I have to learn to make time to do the things that I need to do for me. Because if I don't, I'll be the dead one, and the rest of you all will be going on with life. And I don't want that to happen, so I'm going to change that behavior. Okay, skipping over. Why Why is making long term healthy change so difficult? For one thing, it's hard to change patterns formed in childhood, perhaps even more so among blacks. Researchers have speculated that strong cultural influences on food preferences, food preparation, and perceptions about eating practices passed down from one generation to the next might make it more difficult for black patients to follow a healthy diet. Soul food, especially popular in the South where the largest numbers of black people reside, tends to contain large amounts of red meat, added fats and salt, and is often deep fried. A 2012 study found that a relatively affluent group of participants were less likely than whites to adhere to the guidelines of the DASH diet, widely accepted as the diet of choice for preventing and treating high blood pressure, even when controlling for socioeconomic factors. The doctor could relate. On the cusp of being comfortably middle class, he still couldn't get his act together. Um, he believes that the problem runs deeper than simply the food choices themselves. As a general rule, surveys have indicated that black people are more accepting of, and in some cases indicate a preference for, heavier body types. Skinniness is more likely to be seen as a sign of illness. Surely you have heard some well meaning grandma say, "Baby, you need to put some more fat on your bones, some more meat on your bones. Let me fatten you up." I know I heard that a lot. Um, Skinniness, again, is likely to be more seen as a sign of illness, cancer, AIDS, crack addiction, starving African children, and as a result, lifestyle changes aimed at becoming slender are more likely to be viewed with skepticism than enthusiasm. Dr. Tweedy, had embraced some of those ideas. Despite being a physician, he still viewed some aspects of healthy living, eating salads, drinking water, going to a yoga class, or jogging on a treadmill, with disdain. Employing his own brand of racial bias, he had internalized such behavior as the domain of perfectionist white women who struggled with self-esteem. White men who ate organic food and ran 5 miles a day in the woods seemed to be practicing some back-to-nature philosophy that didn't interest him. Given his struggles with assimilation in high school, but particularly so since starting medical school, adopting those habits to any extent over the long haul meant selling out some essential aspect of both his masculine and racial identity, even if his rational mind knew that such a belief was self-destructive. It was not so much the differences in the food or exercises themselves as what lifestyle change represented. So those are some things to think on. So I've skipped several pages now, and my hand's getting tired, so I'm switching hands. When I started medical school and learned about the adverse health outcomes that afflicted black people, I had assumed these disparities were due chiefly to genetics. To be sure, there are diseases such as sickle cell anemia, lupus, and sarcoidosis which appear to preferentially target black patients at a biological level. But what had become abundantly clear during my years in medical school and as a doctor, however, were the many ways that social and economic factors influence health and more than anything else account for the sickness and suffering that I have seen. The problems take three forms. First are the system-based disparities that limit Black people's access to medical care. Black people are disproportionately uninsured and, if insured, far more likely to have public insurance than private coverage. Further, owing in large part to geographic and residential segregation patterns, blacks are less likely to have access to primary care physicians, and even when available, such care is more likely to involve trainees and other rotating physicians rather than a consistent long term relationship with one doctor. Second, the doctor patient relationship itself serves as a catalyst for differing outcomes. Here, the attitudes and behaviors of both doctors and patients are important. On one hand, some doctors are prone to hold negative views about the ability of Black patients to manage their health and therefore might recommend different and sometimes substandard treatments to them. On the other spectrum, many Black people are mistrustful of doctors and medical treatments to their own detriment. He'd seen how one young man's reasonable assertion of medical knowledge and treatment preferences had left him with what he felt was an improper psychiatric diagnosis. How a young lady had wanted a young lady who was a nurse had wanted a young lady who was of poor background, African American, sterilized after she had a stillbirth, and how he himself had been disregarded by a doctor when he went into urgent care, and I read that last week, until he learned that he was a physician. Over the years, he'd also watched numerous Black patients ignore the sound clinical recommendations of well-meaning doctors of all races. Finally, the unhealthy lifestyle behaviors of many people are also a real factor. He talks about people who were at a charity clinic that he was there who I'm not even going to read this word because I don't know what it means. But they ate only a soul food diet. They lived in an area that I have learned is now considered a food desert. Someone else's drug use had probably caused her child's stillbirth. And another lady had died in a hospital emergency room because of a mix of hypertension, diabetes, and family dysfunction. Um, Another gentleman had smoked his way to a second stroke after having been told he needed to stop smoking after the first stroke. And a young lady had contracted HIV from the sexual life of her ex-boyfriend that she didn't know about. So he says that these stories are complex and illustrate how lasting improvement will only come through an array of changes employed simultaneously. Some of this rests with the government and other large institutions, but most of it must occur at the individual and community level. When it comes to expanding access to quality health care, both government, federal and state, and large private insurers have a major role to play. So I think a lot of what Dr. Tweedy wrote in his book have quite a bit to do with the medical disparities that, or the healthcare disparities that we see in the African American community. And that's not all of them. We've talked about some of the others, about how hospitals were closed down at the early 1900s, the medical schools, and so there were fewer medical schools to graduate African American doctors, and the white schools didn't let them in. So there's quite a bit of rationale and reasoning here for the health disparities in the African American community, and we may look into this a little bit more Thursday, and we may go on to something else. We may look more specifically into what the COVID-19 numbers are showing in terms of zip code and effect of the coronavirus on African Americans. So thank you so much for joining me today. I look forward to seeing you on Thursday, and we will talk some more. Have a great day and stay safe. Bye-bye.